Zoom.
TK Keene.
Present by Zoom.
Thank you. Kathleen Orrick.
Present by Zoom.
Claire Pierce-Roble.
Present.
Om Sukinai.
Yes, here. Good morning, Zoom.
Good morning. And Vice Chair Nashoba Temperley.
I'm present via Zoom.
Thank you. And also acknowledging that we have Mr. Bill Kramer, our OHPB liaison, joining us as well today. So thank you for joining us, Bill.
Thank you.
That completes our roll call, Lindsay.
Thank you, Chicky. Appreciate it. We could go to the next slide, please. Okay, we have our standard guidelines. I just want to spend a little bit of time on. Next slide, please. So we're committed to a safe and inclusive environment for everyone attending. And we're here expressly to highlight our perspectives, and we have differences in opinions and experiences. And we want an environment to share all of that. There are no bad questions, and we invite everyone to participate. Please, if you're able to use the function, please either raise your hand or you can put your message in the chat box. Just make sure you're messaging everyone. We also have real-time interpretation, so it's really helpful if we can speak at a moderate pace and introduce yourself when you start speaking. I'm terrible at that, so I will try to remember. If you can be on camera and that works for you, that's great. It's helpful for all of us together. And please mute your speaker when you're not speaking. And then as Chicky called the roll for attendance, we will do that similarly for voting. Next slide, please. If you are a member of the public, thank you very much for being here. We have several public comment sessions, so please hold your questions or comments until then. There is a session in the middle and at the end. We try to announce those. As always, if something happens that makes you uncomfortable or you witness any unacceptable behavior, please, please, please connect with Chicky, previously introduced herself. We would want to hear about that and make it right. Next slide, please. Okay, the October minutes were in the materials. I think those are October 16th. And so wondering if someone would be willing to make a motion for approval.
It's Ron Gallanet. I'll move the minutes be approved as written.
Thank you very much, Ron. Appreciate it. Is there a second?
I will second it. This is Om Sukinai.
Thank you, Any questions, comments, or discussion on the minutes? Okay. Chicky, could you please call the voting roll on the minutes?
I'd be happy to. Again, when I call your name, please let us know verbally your vote for the minutes. Marin?
Approve.
Thank you. Gladys?
Approve.
Stacy, were you able to join, and what's your vote, please? Charles Fisher? And it was Ron who was first motion. Paul, what's your vote, please?
Approve.
Thank you. Lindsay?
Approve.
TK, what's your vote, please?
Yes.
Thank you. Kathleen?
Approve.
Claire Pierce-Roble?
Approved.
Thank you. Om with second motion. And Nashoba, what's your vote, please?
Approve.
Thank you. The minutes have been passed.
Thank you very much, Chicky. And thanks everyone for reviewing those. Now we're very fortunate to have some time with the Oregon Health Authority Director. So thank you very much for being here. And I know this is a very busy time, but thanks for your time this morning. I think I'll turn it over to you at this point, unless Chicky, do you have any other remarks here?
No, not at this time. Thank you.
Okay.
Thank you, everyone. It's wonderful to be here. I just took a big bite of toast for breakfast, so apologies as I rapidly try and finish that. Appreciate the chance to meet with you today, especially as OHA is navigating headwinds at the federal level, at the state level. There are a lot of challenges I think that collectively we are grappling with. And we're entering a period of much tighter alignment across Medicaid, public health, behavioral health, and now the marketplace. I do want to emphasize that our North Star remains unchanged. And that's really improving health equity, strengthening access to affordable care, supporting healthy families, all of those goals in our strategic plan. But I'm also grateful to be here because the marketplace is central to how we are navigating the moment now. It plays a critical role, as you all know, in Oregon's coverage continuum, particularly for people who are moving on and off Medicaid. And as we navigate HR 1 and maintain the bridge program and prepare for a state-based marketplace, our shared priority must be seamless transition, stable coverage, and ultimately a consumer experience that doesn't force people to start over every time their circumstances shift. And so the SBM transition really remains one of our core strategic priorities, even as we navigate significant change all around us. And we know that an Oregon-specific platform gives us more control over the consumer journey, lets us reinvest assessment revenue directly into services here at home, and allows for the kind of data and systems integration that we otherwise can't achieve. But we can't do all of this work in isolation. Your insight here is essential, especially now as we're seeking again to balance fiscal pressure with the imperative to protect and improve the customer experience. You see in your capacity risks, opportunities, and emerging challenges from angles that we don't. And so I want to make sure that we're learning from that. And to that end, I really would like to spend the few minutes I have with you hearing from you on a few key areas that will shape our direction. And I have various questions. I'm sure you have questions for me, but I'm hoping we can try and focus our conversation on considerations or that I'm grappling with as we approach the coming 2 years. So first, if the goal of the marketplace is to actively pull consumers toward higher quality, more accountable, and more preventive care, I'm interested in this group's ideas about the levers that we should be using, opportunities to align marketplace plan behavior with the quality and accountability expectations that we are setting for Medicaid, for PEB, and for OEB, and some of the more realistic steps that you think we can take in the first 1 to 2 years of an SBM to reduce avoidable downstream spending and incentivize high value care. I think second, on the consumer experience, as we are standing up the SBM, what are features and supports that you think we simply must get right in year 1? How can we ensure that we are adequately supporting otherwise underserved communities? Where do we risk still missing the mark? And finally, on coverage transitions, where does this group see the most fragile handoff points between Medicaid, Bridge, and the marketplace? And what tools or processes do you think could make these transitions more seamless for consumers, for carriers, and for assisters? I think in short, I'm trying to better understand, based on your perspective, as we move toward SBM implementation, where do you see the greatest operational risks, technical risks, and communications risks, and how should we begin preparing now to preempt and address these blind spots? So those are some of the questions on my mind. I think that obviously it's a long road ahead, but to the extent that you can share your input, it will directly shape how we prioritize our work over the next several months. So I'm hoping we can have that type of conversation, but I'm also happy to answer any questions that you all may have.
Thank you very much. Just wanted to encourage folks to come off of mute or raise your hand or drop a note in the box, whatever is most workable for you. It looks like Kathleen, I see your hand.
Yes, good morning. My name's Kathleen Orick, and I'm a care manager in a local hospital, as well as a professor at a local university. And I'm actively working with people who are in need of insurance and very proud of what we can currently offer them. I would say that your greatest risks is currently, we hit that population in the emergency room of enrolling people who are otherwise healthy and having emergent situations. So if there would be any way we could do community focused outreaches to target those populations and educate them on the SBM, that would be great. I know that this group has done a tremendous job of that, but social media platforms, as well as maybe community events to increase the visibility, maybe, looking at farmers markets and shelters and stuff like that to get people enrolled. And maybe even going on radio to increase the knowledge and simplify the message. Also, when we get to delivering care, there's an area that is of great concern to me, which is a recent announcement of the closing of our local LTAC facility. And we're going to have hospitals completely congested with these chronic complex patients. And since you're in a great seat to maybe help highlight that issue, how are we going to decompress the hospitals also so that we can serve these patients? So that's a lot. I'm sorry. I came to the meeting with all of that on my mind. So glad you're here.
Happy to always hear whatever candidly is on your mind.
Thank you for speaking up, Kathleen. Paul.
So this will probably end up more rambly than I'd prefer, but moving to a state exchange is a big win. And the piece that I guess still worries me is that, federal or state exchange, it's still just really complicated, really confusing, especially if you are moving between the various markets. And so for me, it's just figuring out a way to really be able to further empower navigators, producers, brokers, and agents of, whether it is that quality information, whether it is just sort of, hey, how do you navigate what is often a high deductible health plan? And because I think it's so easy to think then, well, I'll just do the ER then versus something else. And I think just whether it's information, whether it's features within the exchange that just put good information in the hands of people that, are just trained and experienced in explaining this to an average person. Anything along that line, I think goes a long way to having a successful transition.
Thank you. I know Cheeky and team are thinking a lot about that on the design side and training side. Is it Nishoba?
Yeah, it is. I just wanted to kind of build on that point, and I appreciate that sentiment, Paul. And Dr. Hethy, I appreciate your time. So welcome to the cohort. I'd be remiss, but I'm to not build on that point. I manage for about the last 12 years a community partner kind of program and navigation team that directly assists Oregonians with enrollments. And so I really am passionate about that for a number of reasons. And to just build a little bit off what Paul had mentioned, that you know, that trust, right, that is built, at the kind of local and organic kind of level with community partners and agents, what I mean, within and throughout Oregon, is really integral. That they have high levels of information and knowledge and can disseminate that kind of more organically and more trusted way. And I think is really integral into reaching specific targeted and most marginalized communities. And so I would really think to strengthen that relationship could be helpful, at least stabilize that program. I've seen that impact firsthand, and I would really attest to that success, and would really hope that we could build on that for a true integration. And I would also just mention, while I have the floor, is that, is exactly that same level of integration, I think, needs to really and truly happen across um, both Medicaid and private plan enrollments. And so many folks transition back and forth due to fluctuating or income or just eligibility. And that is particularly sticky and challenging for so many. Lapse of coverage, misinformation, and just that we really have some models now as we exist here at the end of 2025, especially in some of our close neighbors in Washington, and a true landing page with a functionality to be able to find local help, to be able to apply for multiple different programs seamlessly, and a one-stop shop kind of platform, I think, is really important to truly integrate that experience, instead of, providing more more confusion. But I appreciate the floor, and thank you, everyone.
Thank you, Nashoba. I can see that I think we have time for one more question. I can see there's a hand, but my panel isn't moving. Whoever it is.
Looks like there are a few.
Oh, great. Okay, please just come off mute if we have I think we have one more minute.
Hi, hi, Dr. Hoffing. Thank you for being here today. I would echo Nishoba's comments and questions, but also I would add to the platform. I'm assuming the state platform hopefully be easier and simpler compared to the federal platform.
That's the hope. Yeah.
And because definitely, it's really complicated. I think the average person that we see within the work that we do basically definitely needs a lot of assistance, and it's very complex, especially when you're dealing with a lot of the cost, a lot of the comparing the different types of insurance and so forth. So I definitely feel like if you can definitely work on making it as easy as possible in terms of based on, of course, what you can do, that'd be wonderful, because that's one of the biggest challenges that people once they go into the system, even with somebody assisting them, they still have a lot of questions and doubts in terms of the cost, in terms of the deductible and so forth. It's a very definitely challenging system. So I think, and I'm assuming also, like Nashoba said, educating our community beforehand, the release of the system will be great to invest resources, with a lot of the community partners is so crucial and important. As Nashoba says, they have the trust of the community, but it takes time and it takes a lot of resources. And I know it's going to be challenging times financially, but how can we maximize the use of the community partners to make sure that they have the time to educate people on the new system and do it in advance, not wait till the last minute, but definitely be proactive and maybe starting early, then sooner than later to start the education process. Thank you.
And Director, do you have another minute? There's another.
Yes, please.
Great. Would you like to ask a question?
Me,
Feedback?
speaking as from a broker side, I absolutely echo Nashobi that is the operational system has to be seamless and close to perfect. But talking in terms of the brokers, when I went to a meeting training among the insurance agencies to the insurance company, there's still quite a lot of brokers who don't believe that SBM will really happen. So I would suggest that, in the month of February or March, you might want to do some town hall inviting all the insurance broker to let them know that it's really coming for the year 2026. But overall, even though you have a good system, everything runs smoothly, it's come down to pricings. What is going on right now that people do not renew their marketplace health insurance. So I don't know. I think, the Oregon Health Plan bridge did confuse the consumers a lot. So if my belief is still, if you want people to come in, you just have to have everyone in one system. So if you want to get the SPM to be successful, everyone have to be on the SPM, unless you're on the poverty guideline of 100%. Thank you.
Thank you. All very good thoughts. And I can take them back to the team. I think some may be more feasible than others to implement, but we can continue to have that conversation. And I'm sure Chiki has a lot of reflections that I don't know the rest of the meeting agenda, but based on that feedback, that she may have time to share today itself as well. But appreciate the time, especially appreciate the comments on trust and the need to translate some of that from other programs to the marketplace, as well as to ensure that the design of the interface and all tools, how we structurally set it up, puts members, or rather consumers, at the center.
Thank you very much for your time here today, and thanks to the members of the committee for feedback and thoughts. Any final remarks here from Chiki or anyone else?
Lindsay, yes. So this is Chiki again. Dr. Hosby, thank you so much. Oh, and I think Kathleen's hand is up again. So just wanted to
Yes, I'm so sorry. Just one last thought. As we design nursing education, everything, and I'm sure you guys do this too, everything is geared towards a 5th, 6th grade reading level. And, I think the simplification, I've had people ask me about it. I get asked, I'm not a broker, so I'm not enrolling people. I cannot even imagine what you guys are dealing with. Because you have people who are actively seeking insurance. The people that I'm working with just need insurance due to circumstances, but it's that simplification, easy to read platforms, easy to read charts so that they understand what they're receiving. Thank you for the additional time.
Thank you, Kathleen. And yes, while I know we're short in time, especially with Dr. Hafi's schedule, a lot of these, hopefully these questions and concerns will start being addressed as we have an SPM update here in a little bit in our agenda. And then of course, throughout the year, there's various updates and actually a lot of campaigns and strategies that we are working towards in terms of simplifying the technology experience, as well, definitely the communications and training experience. So more to come. I don't want to bombard you all with details today, but for sure, those are all top of mind. And we appreciate the feedback. And please know that this is not your only opportunity. Again, please feel free to email myself. I'm sure Dr. Hathi also will, if she receives your email, she'll also work with a team to get to make sure we implement as many of your feedback as possible. So back to you, Lindsay. And again, Dr. Hathi, thank you again. We know you have quite the busy schedule, so we appreciate your time very much.
Thank you for having me.
Thank you. Thanks, everyone. More to come on all these fronts. I think next slide, please. Okay, open enrollment progress, definitely still a bit midstream, but looking forward to hearing what we know and input from others. Ready to take it away?
Hello, this is Cable Hogue. I'm the Marketplace Business Policy and Data Advisor. I'll give you a brief update on open enrollment. Unfortunately, due to CMS's data rules, we can't share the exact numbers of where we're at for all the various different metrics we're going to go over, but we'll kind of highlight the differences from the same point in time last year to this year. So as you can see, for enrollments that have been completed as of November 23rd, which is the latest data point that CMS has shared with us, we have a lower number of total plan selections, a lower number of pending auto enrollments. Those are folks that were enrolled as of September 30th and were pinged to be auto re-enrolled in their same plan if they didn't take action. Plan selections amongst new consumers are a little behind the same point in time last year. However, we have seen an increase in total applications submitted and total consumers determined eligible for a marketplace plan. Couple of quick insights into that is I think lots of folks are coming in and seeing what the change in their out-of-pocket premiums are going to be due to the enhanced premium tax credits at this point in time not being renewed for the next year. So I think there's a lot of kind of price comparisons going on for folks, and that's why we've seen a lot of folks come in and complete the application, but maybe not actually enroll in a plan at this point in time, especially given that there's still talk about some sort of extension or new form of those enhanced tax credits. So I think lots of folks are waiting to see what happens with that before they pull the trigger or decide not to enroll. For folks that have submitted those plan selections, we've seen a pretty significant drop in silver and gold plan selections and a much higher selection in bronze plans, which sort of makes sense with those tax credits, the enhanced ones going away. Folks are looking for a lower monthly out-of-pocket cost, and so those bronze plans are going to be the ones that are most affordable premium-wise on a month-to-month basis. While they may not be as friendly with the out-of-pocket costs like deductibles and co-payments, it makes it, easier to stomach on that monthly bill. We can go to the next slide. Maybe, possibly. All right. Quick look at the differences in enrollment at the same point in time for FPL. As you can see, pretty much across the board, we're seeing a decrease in plan selections at every enrollment or every kind of income level, with the exception of folks who are not requesting financial assistance. That's the only kind of data point where we've seen an increase in folks over last year. At the lower FPLs, you can see it's not quite as stark, but that's because those folks, the impacts from the EPTC is a little bit more muted compared to when you get to the above 250% and higher. Obviously, the 400 to 500% and 500% and higher, those folks are seeing no financial assistance at all with the removal of those EPTCs. So that's where it's not shocking to see much higher drops in those folks enrolling in coverage, because at this point in time, they're now back to paying the full premium pocket cost out of their pockets. Next slide. This is kind of some just high-level data points. Average monthly premium gone up a little bit. That's typical for the insurance carriers and their premiums kind of going up a couple percentage points every year. As you can see, the average APTC is actually higher for those who have enrolled in a plan, but the average premiums after APTC is significantly increased with the expiration of those enhanced premium tax credits. Some high-level points for folks who have enrolled or submitted applications. We've actually seen a fewer number of folks assessed eligible for OHP or BHP due to the federal marketplace's kind of functionality. There is no BHP category. BHP is considered OHP in the eyes of that system. So no real way to delineate between the two actual traditional Medicaid versus BHP. Plan selections with a PTC, no real surprise there, has dropped pretty significantly. Eligible for a QHP, we've actually seen a pretty significant increase. Pending auto enrollments, as mentioned before, a little bit lower than where we were last year. Returning consumers, slight decrease at this point in time. New consumers, you can sort of see the difference there, and the total enrollment numbers as shown on the first slide. And next slide, if I have another slide. Nope. So I have a minute if anybody has any questions that they would like me to provide as much information as I can, given CMS's embargo on me actually sharing the exact data.
Thank you. Anyone from the group have a question? I am not seeing any hands. Oh, nope, Gladys, excuse me, please.
No worries. Thank you. Gladys Botwell, insurance broker. Just to reiterate, one of the things that I am seeing is that a lot of people are looking at their what they're going to be paying with nothing else changing. They are losing, a lot of them are losing their tax credits, going from $750 to over $1,500, 1,600, one family over $2,000 just because of their age and their income. So a lot of them are really looking at not renewing. A lot of my people are just like, oh, let me see if I can go down to silver or bronze. And those that can have done that, but those that are already at bronze are just like really thinking about not renewing. So I have a lot of those. So this is really impacting them. So this is very true. Everything that is being shown here is spot on. So thank you very much for such detailed information to show what is happening out in the marketplace. So I just wanted to, from the broker standpoint, kind of go, yep, that's exactly this is correct.
I have a quick question, Lindsay.
Please.
In terms of the gold and the silver, what's the average cost now for in terms of increase for this coming year compared to last year?
Well, actually, Gladys might be able to answer that a little better. It just varies so much based on a person's age, family size, their income level. So, well, the premium itself may not have changed a huge amount. It's those tax credits going away. So as Gladys was mentioning, if you have a couple that are age 60 getting close to that Medicare age, but because of the way age rating goes in Oregon, those premiums could have gone from, with tax credits, maybe $700-800 a month. So like Gladys says, it could double or almost even triple to over $2,000 to $2,500 a month just because of that tax credit impact, especially for those folks who are just over 400% FPL. Those folks are going from having about a 9% out-of-pocket premium cap per year to no cap at all.
Right.
So that can make a massive difference in what they're paying out of pocket, regardless of the actual insurance carrier's premium increase. It's that tax credit aspect completely going away that is making the huge difference.
Yeah, because the increase, when you look at the actual increase of the premium, I'm seeing between $70 to about $180 increase, just depending on various things. But that's whereabouts it is. But once they hit, because before the credit would start tapering down. So a family of two making $150,000, we're getting a tax credit, paying $750, they're 58-ish. But now because of family of two making $150,000, there's absolutely no tax credit. They're looking at $1,600 for a bronze plan. And my other family, like Cable said, if they're over 60, this other family, they went from about $350, they're making about $130, I think it was. They went to over $2,000 on a bronze plan. Some of those that have businesses and have employees, I'm moving them to group plans and going, okay, you're going to pay the same, sometimes less. And now they're on a different plan and they're providing benefits to their employees. So it's the impact of the credits more than the increase from the carriers.
Thank you. So I'm assuming so then we're expecting less people to enroll, or definitely the numbers are going to decrease substantially. Is that what we're expecting? Because of the lack of, yeah, I mean, the cost is just, it's horrible. I mean, it just looks horrible.
I'm seeing it. I have a good dozen people right now, families that are not renewing. They flat out said, not doing it. Can't spend that kind of money. And so I'm trying to see if I can get them into boutique locations where they're paying maybe 150 for concierge. Something. I want them to have something. I want them to not have anything. Looking at the MetaShare plans that they had never been competitive before, and now that might be another option for them. But yeah, there's going to be people that are going to drop and are not going to be covered next year, and it's I don't like people to not be covered. I feel bad for them.
Yeah. Thank you, Gladys. Thank you, Cable.
Yeah, and I will say that Amy has kindly dropped a couple of data points in the chat, including a kind of a informational sort of link to the expiration of the EPTCs and the impacts that those can kind of show.
Any other questions, comments? Appreciate the dialogue. Okay. If not, I think we're ready to shift to notes from the field, I think is the next. Yes. Please take it away.
Good morning, everyone. Misty Reyes, Marketplace Deputy Director, and then Amy will also be going through these slides with me. I think we're going to see a theme here, which is unfortunate, since we've already discussed, what the concerns are as far as enrollments. We can go to the next slide. This one's Amy. Go for it, Amy.
Thank you, Misty. Hello, everyone. Amy Coven. I'm the Communications and Public Engagement Analyst here with the Marketplace, and thank you for having me again. So we have seen strong media coverage of open enrollment this year, mostly spurred, I would say, by the federal talks of the enhanced premium tax credit expiration that we've all been discussing today. So the congressional talks have definitely been spurring a lot of media interest. As you can see, we've had a number of different stories, number of different interviews. It's definitely been busy. We've been focusing really when I do the interviews, definitely focusing on the points of making sure that folks understand, the importance of health coverage, and that although it can be a little bit daunting and things right now, that we do have tools and we do have folks, experts out there that can help with the navigation of these changes, and just making sure that folks know that there are ways to kind of mitigate the impacts a little bit. So when you get these slide decks, I know you can't click on the screen right now, but when you get the slide deck, these screenshots are clickable, so you'll be able to actually read the stories if you'd like to. But I just wanted to share a sampling of some of the stories that have run out there. Next slide.
Yeah, so the general sentiments out in the field is really, for right now, as far as system reporting, there hasn't been any real system issues with healthcare.gov. We have noticed the last 2 weeks we're getting information from our partners, you all, that the assister line is pretty slow, that people are waiting several, potentially hours to get help on the assister line through healthcare.gov, and they're getting transferred multiple times. So we have seen that a little bit over the last 2 weeks, but other than that, the system seems to be working somewhat smoothly. So what's different this year? What we've talked about, right? That concern, that confusion around the premium tax credits, especially the first couple weeks of open enrollment. Many were concerned thinking tax credits were going away, period. just the way it was messaged, not by us, but by others. That's the way it sounded. So many were concerned, thinking they weren't going to receive any tax credits. They didn't understand that the enhanced was the part that was going away. So we had a lot of calls. We had a lot of questions about that in the field prior to open enrollment, and then the start of open enrollment. And then, of course, a lot of concerns about the future costs and being able to afford it, much of what Gladys and Marin already shared. Next slide, please. So we still are out there doing outreach activities. It's interesting too, Kathleen, that you said farmers markets, because we definitely go to those, especially in rural Oregon. Sometimes those are the places where we can catch those people. I will say it's definitely hard to catch people that don't know they're sick and they have emergency services. Like, there's no way for us to know what audience that might be, but we are everywhere and anywhere we can be. So this is just a few examples of some of the events that we're doing during open enrollment. Of course, outside of the open enrollment period, we're super busy as well, getting that word out. This isn't just a short period of doing outreach in the field. This is a whole year lead up to open enrollment. We want people to be aware. We want people to be educated. We want them to know that we're there. We want them to, we want to be there where they feel safe. We are seeing significantly less events this year from community organizations than we have in the past, and also lower attendance. It's likely, well, what they're sharing is it's some of it's due to safety reasons. Consumers are feeling unsafe even going to events that they have went to in the past within their community, due to potential immigration enforcement being in the area. So we have seen that those events decrease this time during open enrollment, unfortunately. And I'll just pause here to see if there are any questions. All right, next slide. What are we hearing from the tribes? Much of the same, right? The confusion around the premium tax credit, the increased burden as far as education and providing that education about what the difference is. And it really comes right off of the BHP confusion too as well. So I know our partners spent a lot of time, excuse me, as did we, explaining BHP, and then maybe that slow processing on the Medicaid side for folks to get BHP has also been hard for marketplace folks, you know, waiting in that limbo. And then now we jump into this confusion around the enhanced premium tax credits. So it's been a lot. It's been a lot for our partners, and thank goodness we have our valuable partners that are helping community understand these changes. But it has been a lot. Oh, I see Kathleen, you have a question. Go ahead.
Sorry, you guys, I'm navigating from two different devices. So, you know, Misty, what you mentioned about lower attendance to these community events, I'd like to echo that, because we actually have parents that are planning to not attend graduations. Yeah. My question would be, can we go to locations like Salud goes out to vineyards and community places where they can help outreach to different specific populations? You know, can we do something like that where the efforts are taken to the locations where people are located, or are you finding just total avoidance? Because I know that we're also seeing that in healthcare, where people who may need home health or need care, they're waiting until they're actually at a critical state.
Oh, that's a great question, Kathleen. So we do a lot of that work as well. So I have regional outreach coordinators, and so they are going to the chambers, they're going to providers' offices, they're going to local things going on like the wildlife safari. We do stuff there. Just people are coming in to go into the wildlife safari. We go to service integration team meetings all throughout the state. So we go to those in person, which have several different community leaders there from different types of resources, and we give them our resources and they hand them out where they're at. We try to be as many places as we can. So part of the team's outreach is not just events, right? It's those going to those service integration team meetings throughout the state. It's going to local businesses when they do their outreach out in the field. It's going to, unfortunately, what are called rapid responses, where we are seeing folks that are either businesses are closed or people are being let go from their jobs. And so now they're looking for coverage potentially. So we also partner with WorkSource Oregon to do that. We have our materials in WorkSource Oregon offices and employment offices. Yeah, we're really trying to be where the people are for sure.
Are we at food banks and local community churches that may have specific populations that are avoiding?
Yeah, we do food banks sometimes. We have found in the past that our efforts at food banks sometimes the majority of the people that go are eligible for Medicaid. And so that necessarily, just because there's been only 7 outreach coordinators and so many places to go, sometimes that's not a good fit for us. But we do have community partner grantees that do attend those events and do give our information as well. So we also have our partners out in the field that, whether they're a grantee or not a grantee, that are trained in the marketplace, that also get our materials. I know Amy wanted to add something too. Go ahead, Amy.
Yeah, Misty, you were just starting to touch on what I was going to add, that a lot of our partners, grantees, or just the volunteer organizations as well, are doing a lot of the work that you're mentioning, Kathleen, where they are going out to the fields to work with the migrant farm workers, or going to the schools, things like that. So we do, to Misty's point, we do focus mostly on the marketplace folks, because that's kind of our demographic of focus. And so we try to look for those types of like the events and the locations where those folks hang out. We do also faith-based outreach as well. I just wanted to add also that it's not only the trouble is not only people not wanting to come to events, but there's also a lot of hesitancy of folks not wanting to provide information on a government application, and worried about how their information is being used. So even as our outreach team or our partners are showing up in community to assist these folks, it's still very very challenging to get them to apply, whether it's for our program or for Medicaid, because of that information sharing and concern and how their information is being used. So just wanted to add that. And to show I see your hand, so.
Yeah, I just wanted to add and maybe challenge the group. I would definitely echo these sentiments, that we're seeing as a community partner and a community-based organization. And I would really challenge us to rethink outreach in that sense as a transition from a physical to a remote and digital based. We learned so many lessons during COVID for connection in actual enrollments, education efforts, and remote and more creative ways that, a lot of organizations are using this opportunity to learn from those lessons that forced us into those methodology into a more optional one. And I would really just challenge us to rethink that notion of outreach, right? That it is a community partner to community partner referral. It is word of mouth referral. It is a trusted, more insular based program, right? And so a lot of organizations like ours are participating less and less in physical spaces, more and more finding referral pathways that are based electronically, folks that can provide a pathway through their trusted trusted groups and communities and community partnerships. And so I would just offer that kind of perspective.
Thanks, Ashoma. Yeah, I think that's a great perspective to have, and maybe start weaving a little of more of that in from what we learned, like you said, from the COVID years, for sure, because that was an interesting learning curve to get people support without actually seeing them in person. Yeah, and I think it would be great. We will continue our efforts. We're always pivoting and changing to fit the needs of community, right? And so we would be more than happy to continue to work with partners and how that works for them and um, to get the community the information they need in whatever ways they prefer. So great thoughts. Thank you. All right. What are we hearing from partner agents? All right, same theme here. Unfortunately, the uncertainty at that federal level has caused many clients to decide to hold off, right? And enrolling, renewing. That's what we're hearing from Gladys and others. That decrease in those tax credits and making it a financial hardship, the sticker shock. All of these things are the things we've been talking about. And then I touched a little bit about on Bridge, right? Many consumers become eligible for Bridge, and that's also decreased our QHP enrollments for this open enrollment as well. And I think Cable touched on a little bit too. Most of our partners are sharing that it's been a slower start to open enrollment, but it's also been a more educational start, as we've already said. Like there's a lot more things to talk about and look at, and maybe people are moving down to bronze plans and so on and so forth. And maybe some people were holding out to see if we were going to get those enhanced premium tax credits, and I think even some are enrolling now, so they're enrolled, right? So that way, if by chance we do get those enhanced tax credits, then they're already enrolled. Yeah, just a lot of stuff going on, but still, main concerns from the agents are very similar to the rest, which you see here. All right, next slide. Oh, I guess that's it for me. And for Amy, any questions for us?
I'm not seeing any hands raised.
Well, thank you all. Thank you all for the time, and thank you for all the great work you do. My team and I appreciate you and enjoy being out there with you all. Thank you.
Thank you for the time this morning and for the update. I think we are moving to public comment. Dawn, do we have anyone registered? No, we do not. Okay, thanks for confirming. Is there anyone on the line or participating by Zoom who wishes to make a public comment? Looking at the list. Okay. I think then, so we have one more public comment opportunity later, so I think we will move on now if that still works. And I think we're headed to SBM updates. You all want to take it away, please?
Thank you. Hi again, everyone. It's good to speak to you again. Victor Garcia, I'm Operations Advisor and Program Liaison for the Marketplace. Pronouns are he, him. And Chicky will also be presenting towards the end of the presentation here. So we've got our state-based marketplace updates here. Just a quick summary of what we're looking at, and then we'll hit these as we go through the slides. So just a timeline, some key accomplishments to date, some upcoming partner engagements, and then some kind of additional detail on some of what's in there specifically for 26. Looking ahead, federal changes that are coming up for the marketplace, and then we'll be kind of diving into more detail after this sort of SBM update on those federal changes, and then what's on our watch list as far as what other states are doing and what potentially we could do, just to kind of put a pin in some things for post-implementation and beyond. So next slide, please. This is our implementation timeline. Hopefully this is big enough. We've got smaller words on the left, but this is the year to come, essentially. This is kind of where everything is going to happen. We are at the top left right now. Just ending at 2025. So We are currently in the process of conducting product orientations. What that is going through the platform as it exists now with Get Insured. Get Insured is, again, our vendor that's providing a state-based platform in our contact center. They operate in several other states. They've done the same transition in several other states with this platform, with this product. So looking at what we have in the list here, kind of cascading down and to the right, it looks like a lot to do in a year, and it is a lot to do in a year, but also we're not building it. It's already built. This is the configuring and making it ready for Oregon. So we are kind of in the just ending the first phase of that right now with our product orientations, and then we'll be moving on to the configuration testing involving external partners and some of that evaluation. And heading towards our launch in November 1st, 2026. So once the new year turns, that's when we'll get into sort of once we get familiar with the platform as it is, and we've kind of seen, compared to our requirements, what we might need to configure, what we might need to make specific to Oregon. We'll work with Get Insured to do that, and then they will kind of stand up our specific Oregon instance to then build on and prepare for open enrollment. So any questions on timeline where we're at right now? I know this is a lot of bars and information on here, but it's a good high level summary of what we have to do in the coming year. Okay, next slide, please. Some key accomplishments to date. So in October, we had various project management plan. These are a lot of these will end up being sort of deliverable pieces of the contract. So we had specific tasks for Get Insured to complete at a certain timeline, and so they have been doing that according to the contract. So we've gotten the project management plan, the project schedule. We've had our first and we have an upcoming one, but our carrier sort of work stream kickoff. So with our insurance carriers, we were able to bring them in, kind of give them a look at some of the things to come and provide some details that they've been asking for in terms of what's going to be required technically to change things on their side of things to connect to the system. So there's still a lot of work to do there, but we wanted to make sure we got at least an early start on that to start setting those expectations and answering some of those questions. And then we had our project implementation budget estimate for upcoming legislative session that we'll be submitting for, I don't think this coming one, but 27 approved. That was part of our stage gate process, and can probably be getting into more detail on that later in the next few meetings. And then for November, we had our account transfer product orientation. That's an important one. That's with our Medicaid One System partners. That's kind of going to determine how the systems talk to each other with passing people back and forth. So we're getting a good foothold there and making sure we all sort of understand the scope, especially when there's dependencies between the two systems on that. And then a few other items there, other kickoff sessions, orientation sessions. These are all, again, sort of preliminary first looks at the system, and then proceeding to kick off with the CMS partners, Centers for Medicare and Medicaid Services. We use acronyms a lot, so I'm never sure when to kind of spell them all out, but they are sort of the approving entity for us to make this transition. So a lot of what we do ends up having to conform to or comply with requirements from CMS. And we'll talk about that a little later too with some of the engagement activities we have coming up. So that was later than it was supposed to be. 11/20 is very late relatively for this sort of thing to happen. That was because of the government shutdown. We actually have a really good relationship with our regional CMS partners, and we're kind of worried, at the start of the year that we might not see some of them toward the end of the year, but they've been great. They've been engaged. We had a good kickoff. So we're there. I think I can say their actual words were, "We're not worried about Oregon," mostly because of how long we've been doing this, but also because Get Insured. So not to say they're not involved, but I think they were less concerned about holding this meeting a little late because we knew both that we were in good hands and have a lot of built up experience compared to other very young SBMs that made this transition in other states. So that's what we have so far. Next slide, please. Upcoming partner engagements, I'll run through these quickly. You've seen these before. So project newsletters quarterly, that's specific to the SBM project. We have partner listening sessions, again, specific to the SBM project, where we listen to agents, community partners, and insurance carriers about our tasks and kind of ongoing input for what we're doing with the marketplace to kind of keep our eyes on the ball. Quarterly updates to the legislature. Our industry communications meetings, we actually have some tweaks to these dates, but those are hosted by our partners, Division of Financial Regulation. They regulate the insurance carriers. So we present information at those meetings to kind of keep everyone updated. The agent, community partner, and marketplace updates are both monthly. Tribal engagements are as needed and as identified by the tribes or by us as opportunities to present new information that they might find important. So that's just a quick summary of our upcoming engagements. To segue to the next slide, please, which is community involvement opportunities in 2026. And the reason I mentioned the CMS requirements before is that we've been hearing consistently and definitely understand where that's coming from. When do we get hands on this? When can we get insurance agents able to see the system, how it's going to work, get the training on that? We are limited in some ways about what we can share and how we can share it ahead of CMS's approval and their sort of notices to consumers that the platform is changing to an SBM. That doesn't happen until very late in 2026. So we are doing everything that we can to get previews, testing opportunities, anything that still complies with that requirement that we don't share specific information before that CMS date, but that we do address the concerns that people do want to be able to see this early and have an idea of how it's going to work before we get to like September. That's nobody wants to do this at the last minute. So we have our partner listening sessions, of course, that's at the top. We have our system testing and user acceptance. So we have our normal user acceptance testing. That's where like the state agency would conduct some formal testing based on requirements. We are trying to leverage that and have Ask Get Insured, and they've agreed to provide a separate environment for some usability testing with our partners. So something that we can actually have external partners come in and look at during that time. So we'll be providing more details when we have those, but that's going to be our early sort of first look opportunity as we are developing and configuring the platform for how it will be in Oregon. And then that will feed into partner training, again, towing that line with whatever CMS says is okay to share ahead of them formally approving us for the SBM that happens in between July and August. We have acceptance. Sorry, there's a specific term that's escaping me now, but it's a term for CMS's sort of go, no go, green light to have the SBM flip over to the Oregon platform from the FFM. And then we have our, we mentioned a line in there, insurance data migration. That's happening mostly behind the scenes, but we are specifically taking the step of when the information comes over from the FFM for all of the enrollees, we are matching Oregon insurance agent data to that to kind of confirm that to maintain the connection between insurance agent and the consumers that they have that they're assigned to or that they've been approved to have plans for, so that connection doesn't break, so that they're still the agent of record for those plans for those consumers. So that's a specific body of work that does require our involvement, and if need be, we can sort of most of the time there's some sort of validation or verification period between October and open enrollment November where agents will be able to kind of get in and take a look, but we'll find out more about how that works in the coming year. So that is on our radar. We have definitely heard that and are going to make sure that that happens the way it's supposed to. Public system rollout, that's targeting soft launch for October 1st. Again, that's pending CMS's like messaging that this is happening. Once they give us the thumbs up, we'll conduct a soft launch that's basically opening the system to folks. Can enroll people in that time. But we can sort of have the call center available. We'll be able to answer some preliminary questions. We'll have a complete scope of what's going to be available during that soft launch period, and people should be able to preview plans at that time as well. So they may not be able to actually put things in a cart, but they should be able to see and shop and see potentially what tax credits will be, things like that. And then once we go live in November, move to operations, and then of course ongoing support will be after that. So this is kind of where we see, I guess, where our connections to our partners will be starting in March with kind of hands-on, but then going through training and everything else through open enrollment. As Misty and Amy were mentioning before, the community partners and agents are extra hands. Really, we don't have enough marketplace staff to just do all of the outreach and connections to all of the consumers that we want to. So being able to provide them the tools and information that they need to do what they do properly only benefits us more. So the more we can help them do their work effectively, the more it also helps us. So that's our goal, is to continue to listen and continue to make sure we provide these opportunities to, again, gauge early and provide feedback on the platform. So any questions on that? Oh.
Yeah, Victor, good morning. It's How are you?
Hi, good, thanks.
I've probably forgot. Is this SBM system will be concluded with OHP? Like people want to sign up for Oregon Health Plan can use the same system, or they still have to go to one.oregon.gov?
So if people do start an application in the marketplace and end up, being not eligible for APTC, but eligible for OHP, they will be referred to OHP, and some information will get transferred from the system, but they will still have to go to the the one system, the OHP portal, to kind of finish that, to enroll there. So it won't be able to take care of enrollment, but we are working to make that handoff as seamless as possible. And we have some slides later on that will talk about some of that. But that's the as close as we can get to having just one system where everybody signs up. There would be some advantages there, but there's also some advantages to having sort of each system kind of independent of the other. And that, unfortunately, one of the downsides is you do have to go to the other portal at some point to enroll in or finish the enrollment for OHP.
All right, thank you.
Mm-hmm. Yes, Marin.
Thank you, Victor. So can you share what are the main changes or the differences between our system and the federal system? If you can share that, I don't know if kind of like in general scale, what are the main differences or the aspects of it?
Yeah, definitely. Hopefully somebody can play me off with music if I'm going on too long. But one of the primary differences is going to be our ability to respond to feedback. So right now, let's be clear, the FFM actually does what it's supposed to do. People are able to enroll. It doesn't, it's not broken. It is a functioning system, but we have no input. Oregon has no input into how that system is run, the programs that can accommodate. If we want to do specific things in the system, they won't be able to really accommodate anything specific to Oregon unless they're really doing it for all the other states too. So that's kind of number one, is our ability to have control over the buttons and levers of the operations of the system, so that if we do end up with something like a premium assistance program, or we do end up wanting to make an Oregon specific special enrollment period for people that are pregnant, we can do that, and we can actually make that happen. Whereas now we can kind of shout into the void towards CMS's direction, but we really can't make that happen. So that's going to be number one. A few of the other differences will be the contact center will also be specific to Oregon. So when people actually call, they'll be calling into something, again, that we sort of have control over the buttons and levers of, that we have input into the training materials, and the way people handle the calls, the prioritization of what's our most important metrics, which are all going to be sort of customer service oriented. So at the end of the day, our most kind of top priority there is to save everyone time. is to make sure that if someone does call in needing support, that they're able to get that support in as quickly as possible, but also as efficiently and effectively as possible. We don't want to just get them off the phone, but we do want to help them quickly and make sure they get the right thing like the first time, and they don't have to call us back and then OHP back and then us back again. So reducing the amount of time that everyone involved, including consumers, but also agents, community partners, have to invest in every interaction that may require that sort of phone call step will hopefully kind of improve everyone's experience overall and make the idea of dealing with the marketplace not such a seem so burdensome. And with the domino effect of encouraging more people to kind of enroll in having that positive customer service experience, word of mouth, that sort of thing. So those are our main focuses. In terms of look, feel, there will be some differences we'll be able to make in terms of our application. So there is some federal guidelines about what the application has to include, but as long as we are conforming to those requirements, we can make some changes. So if we ask some more specific Oregon RealD and SOGI questions, that we can do that as long as we're explaining how we're still meeting the requirements to CMS, but then we can kind of make those more detailed and more important sort of demographic measurements that we want to make, but also, help people feel seen in the way that prefer to be seen when they're enrolling for health coverage. So those are all the sorts of things, again, that gets back to buttons and levers control. That's just some examples of the sorts of things we'll be able to change. And then, of course, getting constant feedback and input from all of our partners to be able to evaluate what else can we do and what else can we suggest that maybe we can't decide unilaterally, but we can say this is possible, so that then lawmakers and others can make those decisions to possibly implement those things. So those are all on our radar. It's a lot to kind of have going at the same time, but they're all the reasons we wanted to do this in the first place. So and I'm not sure if that really gets to what you were asking, but
yes, thank you.
And yes,
More questions. I'm looking your timelines. Everything seemed to be looking good. And of course, I'm excited about this SBM, but I'm kind of want to know if you look into crystal ball, is anything you can foresee that could have a negative impact that make the SBM not successful as we hope? Thank you.
Sure. My crystal ball is a little fuzzy in places. So in terms of the actual project progress, the partners we're engaged with, the vendor that we have on board, Get Insured, the track record other states have doing the same thing, all of that points to a clear path to November 1st with really not many speed bumps or any speed bumps potentially dealt with in a way that has already been addressed before. The places where that crystal ball is super dark is around sort of federal actions and regulations. We don't know what's going to happen because so far 2025 has already been a year of very unprecedented things. We'll be talking about a few of them in the next presentation section. So that's kind of the thing I'm most worried about is weird regulations that come kind of out of left field that don't really have any consumer protection focus, anything that's really geared at helping anyone, but really is just a political cudgel of some kind that then states have to conform to with their SBMs. Even with that possibility, I think we're as well positioned as we can be with our partner, again, Get Insured, and really the support of other states that will be going through the same thing to be able to still implement that in a way that's workable. So it really just depends on where a lot of that goes. And then, of course, the other sort of things we have no control over that nobody really has control over, which is the sort of natural market forces of insurance. So try our best to make sure we get information out there. We engage our partners to help communicate potential paths for coverage that people have. But ultimately, people have to make decisions about what's best for them. And if they simply can't afford things, there's no way we can make them afford it. So that's kind of one worry, is not knowing where really the market will go. And again, that's something we have no control over. So from a planning perspective, from preparing the SBM technically, from a project perspective, everything all of the clockwork is on time. It's all working the way it was designed. It's really just those unknowns that could throw some gears in wrenches in the gears that we really can't foresee. So those would be the biggest ones: federal changes and market forces that we can't really predict.
Thank you. Thank you.
And I think
Okay.
I'll hand off to Chicky.
All right. So again, Chicky Flowers, pronounced her, she, her, hers, Shakanen. I'm the director of the Oregon Health Insurance Marketplace and also the project sponsor for the state-based marketplace project. So speaking of crystal balls, we try to clear it up as best as we can, but there are a lot of things that are not within our control / purview, especially in the federal landscape. So the next two slides will talk about the federal changes that are impacting us or we know will impact us in future plan years. And those are the things we know as of today. So wanted to flag for you two key pieces of federal guidelines that inform these two slides. First off, it's the HHS Marketplace Program Integrity and Affordability Rule that was released, I believe, in the spring of this year. And then, of course, the infamous HR1, which came not too long after. Ever since then, of course, there's been a few challenges to a lot of these federal provisions. For example, we noted here in the footnotes, so there are a few provisions that are currently stayed by the City of Columbus versus Kennedy case that was issued in August. So please know again that these are federal provisions we know as of today. Some of them are currently in effect. Some of them will be effective in plan years 2027, 2028. And then of course, there's some of those provisions that are currently stayed. So a lot of moving pieces, a lot of things that we are already considering and working with Get Insured to make sure that these are part of the system when we go live on 11/1/2026. So kind of going over some of those things that what you have in front of you are what are the provisions that are effective as of today, unless they are stayed, so 2020 for plan year 2026. So please note that the healthcare.gov is responsible for making sure that these changes are implemented in their system. So for example, the removal of advanced premium tax credit repayment caps. And then of course, some non-citizens with incomes under 100% FPL are no longer be eligible for premium tax credits. And also the pre-enrollment income verification standards and SEP or special enrollment period verification standards are stricter for this upcoming open enrollment period. And that's the one that has been stayed by the City of Columbus versus Kennedy. The items in bold on the right column, the opportunities for state mitigation starting in 2027. The items in bold are the ones that we are already working towards and making sure that we have, that we are working towards in terms of strategies and other campaigns to help mitigate the impact. So let me pause there to see if anyone has any questions, but please know also there's only so much we can do because we are in healthcare.gov. So if we need data, we can't get that. If we need to do more specific training or or communication directly to consumers, we're very limited in our ability to do that as well. Okay, looking quickly around the virtual room, I don't see any hands. If we can please move forward to plan year 2027 and 2028. These are, again, the federal changes that we know we are required to implement. So starting with our open enrollment on 11/1/2026 for 2027 plan year, the federal provisions that will be impacted are refugees and asylees will no longer be eligible to receive premium tax credits. And there will be a shortened open enrollment period starting with a 2027 open enrollment period. So the guidelines is open enrollment will start no later than November 1st and can end no later than 12/31. So right now, marketplace open enrollment goes through January 15th, and state-based marketplaces have the opportunity to hold their open enrollment period for as long as possible, as long as it doesn't extend past the calendar year. And then starting in plan year 2028, automatic re-enrollment will no longer be allowed. So we are looking to implement changes to automatic re-enrollment to minimize enrollee disruption and ensure consumers maintain coverage from one year to the next. So we are exploring a lot of different things, and we don't have everything set in stone at this time. And we will definitely bring back to this committee kind of all the different strategies that we've heard from the field in terms of what we can implement. or we should implement for plan year 2028. We'll bring that back probably in 2027. It's a little too soon to think about those things. We have to think about one plan year at a time, but please know when we think of opportunities for state mitigation, we will bring back to the community, the committee and the community to solicit feedback and all the fun stuff that we are hoping to be able to do with our state-based marketplace. Okay, any questions so far? So going back to the crystal ball question, so it's there. We see some things, but I'm sure there's a lot of things we don't know. One other piece of federal guidelines that we are anxiously waiting on is the annual notice of benefit and payment parameters. That's another vehicle that the federal government uses to help implement, well, first they ask for comment from the state and from the states and the communities to provide kind of feedback on the different provisions they want to put forward. And then after the comment period, it becomes final. So that's an annual process. We expect more provisions to be introduced and potentially implemented by the federal government for all the states through that vehicle. So we have two pieces, and then we have another piece that we're anxiously waiting on. Hopefully in the next couple of weeks, we will have that released by CMS, and we'll have more insight into that. Next slide, please. So Marian, you asked, hey, what's the difference of moving away from healthcare.gov? And Victor did a fantastic job of highlighting some of the overarching themes of what we're looking forward to moving away from healthcare.gov. What you have in front of you is a quick snapshot of some. A lot of states with state-based marketplaces have been innovating left and right. And here are just some of the most popular innovations in other states, SBM states rather, that is we're closely watching in terms of being able to figure out if that's something that we want to do in our state and what we can operationalize. So for example, some of the popular innovations are easy enrollment via tax filing, where citizens, when they file their taxes, there's maybe a question, do you have health insurance? Yes or no? And then that information gets transferred to their state-based marketplace for further due diligence. Also, same concept with easy enrollment via unemployment insurance. A lot of states also have extended open enrollment periods whenever they can. And a lot of SBM states also have special enrollment periods for pregnancy. And then we also have other SBM friends who have state premium subsidy programs to help mitigate the impacts caused by EPTC expiration and other things that are, making health coverage a lot more unaffordable for their citizens. So that, committee members, ends our presentation, at least for this session, for the SBM project updates. Do you have any questions for Victor or I or the rest of the marketplace team who are really, really getting into the weeds of all things SBM implementation?
Not seeing any hands. Looks like no questions, Chicky.
Okay, thank you. And again, the offer is also available. Again, we once again make this offer. If you have any information, requests for information or questions, we would be happy to, of course, send you more information outside of this meeting. So please make sure to email myself, Dawn, or Victor, and we'll make sure to get you the information that you are looking for.
Thank you, Chicky. Before we head to break, I just wanted to round back and not to put you on the spot, sir, but wanted to congratulate Commissioner Kane on being named to the full-blown permanent insurance commissioner role, and just wanted to acknowledge that and congratulate you. So if you had anything you wanted to say, we would welcome that. But again, I am putting you on the spot, but congratulations.
No worries. Thanks, Lindsay, and thanks, Chicky, and just really happy to continue to be part of this group in the role, and really happy to see this morning all the great progress the marketplace team has made on our own exchange. That's really wonderful news all the way around, and I know a lot of hard work goes into that. So just really appreciate being here and being able to participate in the conversation, and look forward to working with all of you. Thanks.
Thank you very much. I think with that, we're going to take a break. We will reconvene at 10:40, everyone. See you then. Thank you. Hey everyone, it is 10:40. If you're back, if you had your camera on before, if you could just let us know by adjusting that if you're comfortable so that we just make sure we've got critical mass back. Hey Gladys. I don't know if you saw me earlier. I look like I was trying to attack my light switch, so it keeps shutting off. Okay. Thanks. Okay, looks like we are in good shape here. Can we have the next slide, please?
Just a second.
All good. No, I figured it was fighting back.
Where that went. Just 1 second.
Okay, don't worry about it. Earlier, I couldn't get any of my panels to move, so technology is all the fun. Maybe while the slides are fighting. Oh, there we go. Thank you, John. Victor, do you want to take it away?
Thank you, Lindsay. Hi again, everyone. Welcome back. Chicky previously in the last segment was talking about some of the changes coming from HR1, and we just have a couple of slides here talking about how we're implementing those changes or anticipating those changes in our SBM project. So this is how we're preparing for those changes that Chicky previously talked about. There will be some overlap of information, and I'll probably run through some of that overlap pretty quickly. But if more questions have come up in the meantime that you remembered or anything else you want to ask, please feel free. Next slide, please. So these are some of the changes, again, that Chicky just went over of changes requiring SBM updates. And Dawn, I think some kind of menu popped up over some of the information there. Thank you. And this year we're looking at DACA recipients that are no longer eligible. So Get Insured, again, operates in other states, and they've already made changes to comply with this rule in other states. So this is already kind of ready in the platform. And I guess I should stop here just for a moment to say, when we talk about these things, especially HR1, I made an effort to go through a lot of HR1, and these 3 slides represent a tremendous amount of distilled work from the entire team, just from a policy analysis perspective, and lots of back and forths on potential impacts. But what none of us could really find is any provisions in here that were really aimed at protecting consumers in a meaningful way. There were a few small things that addressed some fraud, but really it was mostly geared towards making it harder for people to enroll. That's kind of what we pulled away from it. And it's going to probably do that pretty effectively. So it will make things a lot harder for a lot of people. So when we talk about the changes that we're going to have to make to the SBM project, the end result is they're technically not very difficult to do, but morally, they're very difficult to do. We understand that this is going to impact a lot of people in a negative way. So this is to assure folks that we are anticipating what the changes are and able to effectively implement them in the SBM system in a way that is compliant with the law, and that will enable us to continue using the Oregon-specific marketplace platform. But that we also understand that a lot of these changes from HR1 are actually causing harm, and that our intention is only to be able to allow people in Oregon to enroll in coverage as the law allows, even if we don't agree with the law. So with that preface, these are the changes that we're making to some of these, according to some of these requirements. So we also have the immigration status, 5-year bar population no longer eligible for APTC. We just have to make sure that there are changes that accurately refer those people to the one system. I think the slides just disappeared.
Yep, they just dropped.
And that might be a result of the same kind of And so I can just cover very quickly. Chicky also mentioned the shortened open enrollment period. We don't really have any control over that from a federal standpoint. So while being able to have an extended open enrollment was one of the big drawing features or appeals to having an SBM, now that it's capped at December 31st, it's capped at December 31st, and we're going to extend that, as far as we can. But also, we're exploring some options with other states, talking about, what's within the rules, what's still compliant, but will still give some more flexibility. Maybe not related to open enrollment, but maybe special enrollment periods, things like that. Things that, again, we're not trying to get away with anything, but just making sure we leverage our ability and still remaining compliant to make things easier for people when there are other factors making things harder for people. Asylees and refugees are no longer included in the definition of lawfully present. So that requires some changes to the way the application is structured. And I should also add here as well, a lot of these changes that we're talking about too are changes to sort of the base platform, but really for the position that we, as the marketplace in Oregon, are in, just implementing the system in 2026, that actually makes things easier for us in a lot of ways. Trying to change something that's already in place and already in production and functioning for a number of people already enrolled is a lot harder. So I don't want to kind of downplay how difficult this might be for other states or anything else, but for us, it's technically not as difficult, again, because we haven't gotten off the ground yet. We still are able to make these changes in our initial kind of production run. And we have the time to be able to do that. So we're not forced to do anything right this minute to change something that's already in place right now, but we have a year to prepare. So that's just a little more context as we talk about some of these changes. And then, of course, the in 2028 ending automatic re-enrollment, that's going to be potentially a big one. It will require people to actively get in and manipulate their application. Right now, there is a lot of enrollment that happens during open enrollment that is automatic. It is people that have already enrolled in a plan, have authorized the exchange to be able to re-enroll them when that time comes in the next year. And then that ability is going away in 2028, at least according to the regulations as they are now, barring something else kind of mitigating in the meantime. So we do have to prepare for that probability. Next slide, please. So in our current mitigation strategy for refugees and asylees and them losing Medicaid and premium tax credit eligibility, we can basically enable more accurate pre-screening of those people when they apply, and those that are potentially eligible for OHP Bridge, or other one programs. And we are able to do things for the one system in a way that the FFM is currently doing for the one system. So the effort on our side will be to increase the accuracy of those assessments to make sure people do get wherever the right place is, that they do get there the first time, and that there aren't any extra steps and there are lots of little wonky policy specifics and things that can get people into sort of a loop where they're like not eligible here, so they go there, and then it appears they're not eligible there. And then, so we want to prevent loops like that from people going back and forth. We want to make these transitions as seamless as possible. And we do have the potential to do a lot more. I do apologize if there's a lot of noise. There's people working outside, so I'm not sure if that's coming across, but I'll try to speak up. And we can improve this upon this even more. But getting back to the last slide that Chicky presented about some of the potential improvements we can make with interactions with maybe the DMV or Department of Revenue or others. Anything that relies on two systems making changes kind of needs both systems ready to do that at the same time. And so we can't always guarantee that when we're ready to do something, one system is ready to do something and vice versa. And for all the things we have to think about when it comes to HR1 implementation, impacts to Medicaid, that laundry list is much, much bigger. And things like Medicaid work requirements and things like that are just almost impossible to wrap your head around. So at the moment, we're really not asking much more than what's needed to get implementation in November 1st, 2026, but we're already working now to see about improvements that we can make beyond that, and see if we can get those on the schedule once things calm down a little bit. So again, that applies to kind of any partner we're potentially looking at working with. We have to make sure that even if we have some ideas we want, and we already have it mapped out how we're going to do it, that they have to be ready to do it at the same time and have those complementary changes ready. But we are constantly thinking this over and constantly talking this through with internal and external partners to make sure we can get it as clean and accurate as possible. Next slide, please. And so a lot of what at least prefaced the HR1 changes was fraud prevention and detection. So the first couple are determining fraudulent enrollments, the HR1 kind of documentation, and before that the program integrity rule that CMS passed kind of talked about this a bit before pivoting to the last point there. But I should also preface this by saying when we talk about sort of fraud, especially insurance agent related fraud, it hasn't really been that big of a thing in Oregon, and it really represents the smallest fraction of bad apples in our agent community. So this isn't something that at least we don't think should be considered widespread in Oregon. We have great regulation from DFR. Agents have kind of specific standards they need to conform to, and it's kind of more difficult to get away with that sort of thing here, but it does happen. First is, of course, only approving insurance agents who live and work in Oregon to do for exchange plans, for marketplace plans. So we'll kind of take over the certification of the agent that are able to participate in the marketplace, and that's one step we're taking. And then assisting carriers in determining patterns of fraudulent enrollments. So we have had some fraud, as I mentioned, and then inpatient drug, alcohol rehabilitation centers, things where people could get away with sort of using somebody's information to enroll in a way that they weren't even aware of. I guess in our case, our carriers had actually identified this fraud and alerted CMS to that. So they have an investment in making sure that doesn't happen as well. And so with an SBM, we can potentially, with our access to the data that we currently don't have, take a look at that data and identify those fraudulent enrollments before even carriers notice them, or we can act a little more quickly when carriers do. So in either case, we'll have more tools at our disposal to identify any potentially fraudulent activity as we implement the SBM and as we improve our sort of data analysis capabilities and work with other states who are also trying to identify the same kinds of trends. So we're constantly updating each other about things to look out for. So with all those mechanisms in place, our ability to detect fraud is at least as good as the FFMs would be. And because our scope is much smaller and we can focus on Oregon, we don't have a lot of concerns about detecting fraud at the level that's expected. The last point here is improving processes to reduce improper enrollments. Now, improper enrollments were something that the rules kind of pivoted to the program integrity rules. So they talked about fraud and then suddenly pivoted to improper enrollments, which really could be for a number of reasons, which usually aren't fraud. They're usually people that have applied for the wrong program or maybe have included information that pushed them into one program versus another that wasn't accurate. In any case, there's no data really supporting that this is a widespread issue in Oregon, but it is also something that speaks a bit to program controls. We really don't want people enrolled in the wrong place. We do want to get them to the right place, and we do want to improve the mechanisms that make sure that people do end up that place the first time. So between our improved ability to handle customer service calls, communications, and referrals to the appropriate entities to mitigate a lot of these issues, we should be able to reduce the occurrence of improper enrollments that come from Oregon from a federal perspective, and hopefully their analyses will bear that out. But again, I should reiterate that a lot of these haven't really been widespread problems. They are concerns. Our primary concern would definitely be consumer protection over most other things. So a lot of these were kind of looking at, were people getting too much APTC or things like that, where didn't necessarily seem to be intentional in a lot of cases. So at least from, the rules perspective that came out from the federal side. So, but we are aware that these are important, and these are all things that are already built into like the operations of the platform, but also that we're looking to improve upon as we go and work with our partners to improve. So hopefully that's just a little primer for what we have. And I think the next slide is the next section. So any questions about any of what we just went over? Hopefully that addresses some of what Om was speaking to in terms of, being ready to implement, and any concerns in the crystal ball about what's coming. HR1 and federal changes like this are at the top of that list, and we do go through. And I should add, Get Insured had presented in an earlier meeting. They go through a similar kind of thing because they serve so many states with marketplaces. They have to sort of be on the ball when it comes to what's coming from a federal perspective, what changes are expected, what new things will we have to conform to, and then we kind of match up our lists to make sure our priorities are the same, but also that we anticipate making the same kinds of changes to comply. And so far that has been working very well. So we're looking forward to moving ahead with those. And with that, I will hand it over.
Looking here, I don't see any hands raised. Okay, thank you very much. I think next we're hoping for a reflection from Director Pierce Robel. Would you like to take it from here?
Absolutely. Thanks for having me today. And I think ask here was to look back over the past year, because I've been here for 1 year at OHA as the Health Policy and Analytics Director. And I think, as Victor just accurately described, it has been a year of a lot of policy change and a lot of changes that are impacting the healthcare system and impacting the way that people are able to access healthcare coverage in the state of Oregon and nationally. And so I think the biggest kind of challenge in front of us will be continuing to grapple with what the impacts of HR1 are across our systems, and the changes that will be made outside of the marketplace, but are certainly going to be impacting the marketplace. And as people are moving from different types of coverage or throughout the system, our Medicaid program in particular is going to be taking on a lot more work and administrative burden, frankly, to keep people enrolled, as they are now navigating, or going to be required to navigate starting at the end of next year, a system to provide proof of work or other exceptions that meet the work requirements that are a part of that. So that's going to be a big lift for the state. In addition to that, the new eligibility changes on the Medicaid side mean that we need to check eligibility more frequently, which is a parallel to the to auto enrollment going away in the marketplace side. So basically, more opportunities for people to interact with the system, more opportunities for, as we know, people to then fall out of the system because that paperwork can be a deterrent. And it's perhaps not just paperwork. I heard from many of you in sharing your thoughts with Director Hoppe that there are all the other chilling effects in place right now, in addition to the financial costs and increases as financial assistance goes away. So all of these things are really creating what I see as somewhat of a burning platform to address what's underlying all of this, which is continued high cost growth and high healthcare spending, which then contributes to the premiums that we're seeing and contributes to people not being able to afford their healthcare even when they do have coverage because of the costs of that care. And so the work ahead, I think, for us at OHA, and I'm happy to be working closely with the Oregon Health Policy Board on this, is to look at healthcare affordability and what the mechanisms are and what policy levers we might have to address what we are seeing. And that affordability committee was just launched in the past few months by the Oregon Health Policy Board. And there's a sister committee, the Industry Advisory Committee, that will also be informing that work. And that group is really tasked with coming up with recommendations that look at kind of both sides of this affordability crisis, both the short-term solutions, which can be, pejoratively referred to as Band-Aid approaches, but for individuals who need healthcare, who need to access services, it's really not an option when there are these costs in front of them right now that are perhaps preventing them from enrolling in the marketplace. And on the other side, recognize that we need more long-term solutions to fix what's really happening. And one of the other programs that we run in the Division of Health Policy and Analytics is the Cost Growth Target Program. And this is a program that looks at those underlying costs year over year and where healthcare spending is changing. And we're looking at that in the commercial market, in the Medicaid market, in Medicare, and really digging in at service line levels and seeing year over year what those trends look like. And also a part of that program is holding payers and providers accountable for exceeding cost growth targets that the state has set without an acceptable reason. And really the intent of programs like that is to say, look, we hear from consumers and we are hearing from everyone who is trying to access the healthcare system that the costs are too high. The origin of the Cost Growth Target Program was almost 10 years ago now, and looking at the state of the world even then, Oregonians were facing higher deductibles, higher prices in other parts of the country, higher healthcare cost growth that was well exceeding wage growth in the state, and that was really exacerbated in the state of Oregon. We now kind of come to today where in that intervening time, there have been these periods of financial assistance, enhanced financial assistance to access healthcare, but those underlying costs haven't really gone away. And those underlying issues are still persisting. And so it is a kind of call to action in that way to understand that we need to be doing things differently and better. And we can't just keep doing Band-Aid approaches because they don't actually fix the underlying problems. So I'm excited to work with that group, the Affordability Committee, which I sit on. And I think the other side of this that is relevant to hopefully this group, and as you're interacting with consumers that are looking to enroll in coverage and make sure they can see their doctor, is that we really need to address the primary care workforce. So we have been hearing through other programs that we oversee in health policy and analytics that through our workforce needs assessment in particular, that we are really facing a primary care crisis in the state as well. We are not replacing primary care physicians at a rate that they are leaving the field, and we are really not replacing primary care providers at a rate that meets even the current demand. And we are, that demand is outpacing supply already. So we're really in a critical place there too, to make sure that the primary care system is sustained in a way and paid in a way that ensures that people are able to access primary care and access preventive care services, which could avoid more unnecessary costs or hospitalizations down the line. It's just the foundation of value-based care in a lot of ways is that access to the primary care system. So similarly, we are supporting under the direction of the Health Policy Board and OHA leadership, a new primary care workforce initiative that is intending to look at some of these options that we have in front of us. What have we done already to support patient-centered primary care, and we have supported that through, for instance, the Medicaid program, which provides additional payments to primary care practices that are identified as a patient-centered primary care home, which is another HPA program where we certify those primary care homes, and then Medicaid is actually paying an increased rate to those practices that are providing care at that level and meeting that standard. And so where can we find ways to ensure that those primary care practices are invested in so that they are sustained and will be available, so that when we are when this group and everyone working on the marketplace is getting folks enrolled, that they do have access to primary care at the end of the day. So I think those are a couple of the really critical things that are in front of us. And I think the last thing I would just share, and then happy to take any questions or engage in any other conversation, is around a quick update on our Rural Health Transformation Program application. Again, this is not fully in the purview of Marketplace, but it is really a it is agnostic of payer or market. This is a program that was authorized by HR1 to invest in rural healthcare transformation across the country. It is a limited 5-year funding that we applied to. All 50 states were eligible to apply, and we are expecting to hear back from CMS by the end of this month. And those funds, if we receive them, which at a baseline would be $100 million per year for 5 years, and upwards of $200 million per year, those would all be funds that we are pushing back into rural communities in particular to support things that are transforming the delivery of healthcare in a way that ensures more sustainable access to care. These funds can't be used, and frankly couldn't be used, to replace the lost Medicaid funding that the state is expecting as a result of HR1, but it can be used to think differently for regional collaboratives and community organizations. And I think about whether that can also include agents and navigators and other CBOs that are working with marketplace enrollees to come together and see where there are solutions that this funding could be used for to deliver care differently, navigate healthcare differently, and make rural healthcare more sustainable in the future. And I know that is not an easy thing to do, and is certainly not something that is going to be achieved in 5 years, but we are very hopeful that this federal funding can be used as a catalyst to support some of that work, and to support certainly more investment in regional collaboratives that can look at right-sizing care options in rural communities that are struggling to maintain the current levels of service. So that was the last thing I just wanted to mention. And I can also, if folks are interested, I will drop in the chat a link to our website that explains the application that we submitted to CMS and some of the timeline about when we are hoping to hear back. And we also have open at the moment a survey for any interested organizations to provide information about what they would be applying for and what programs they would be looking to get funded once the state actually receives this federal funding. And so this will give us a better sense. This is not binding. We're not going to be using this for specific funding decisions, but it does help us to plan for what's out there and how we can hopefully negotiate with CMS for the maximum federal funding possible under this program. So I will stop there and happy to take any questions.
Thank you. Folks want to raise their hand if you have any questions. Just look in here. Kathleen, and then Om.
Good morning, and thank you for that information. I am concerned also about the lack of primary care physicians because we deal with that quite often. Another layer to that of trying to replace those who have chosen to retire, because there was the whole baby boomer generation of physicians that exited at the end of the COVID time frame, is that now the new generation of prospective students going into who may be considering primary care are also looking at the potential of their loan reimbursement plans being eliminated through executive orders. Is the state considering any type of tuition assistance or working with universities to help pipeline this next generation?
Thank you for that question, Kathleen. And I think that we share those same concerns about the decreases in federal support and investment, and indications that the Department of Education might be changing loan caps for certain types of clinicians. We have authorized by the Oregon legislature a program called the Healthcare Provider Incentive Payment Program. There are a few different ways that we are supporting, that the state is authorized and has been appropriated dollars to support folks that are training in and continuing to work in the state of Oregon, especially in rural areas. And that does include loan forgiveness in some cases. Those dollars are obviously limited, so the ability of the number of providers that we're able to support is limited, but we do really see that as a critical piece of the puzzle. We also manage part of the programs, HRSA programs that similarly offer loan forgiveness and support for physicians that are training in primary care. And so there's a few different options. I can also share information about those programs in the chat if you'd like to learn more. And I think the idea with the primary care committees and work that I mentioned would be to kind of look at the, incentives or loan forgiveness piece as one part of the pie, but then what does the reimbursement structure look like? What does, at the end of the day, some of the administrative burdens that have been placed on primary care that lead to burnout, that lead to, if providers aren't completely leaving the industry or leaving their practice, they're at least cutting back on time, which similarly exacerbates those access issues. I think everything is on the table to look at what we've heard through the Healthcare Workforce Needs Report and other forums so that we can make sure that we're addressing this multifaceted issue to the best that we can.
Hi, Claire. This is Alms. I am a broker. I really want to thank you to emphasize on the primary care provider, which is such great things. But this, my comments could tie into public comment. In terms of affordability of the health insurance that, if we forecast that it's going to be hard to get the premium coming down, I'm kind of thinking outside of the box in the looking at a big picture. I don't know if this possible or not to, have the legislature take a look into giving Oregonians some tax credit on their health insurance premium. In general, I think, if you pay $1,000 up to $2,000 that you can write off that deductions, that might help people to stay in the health insurance and have, coverage instead of rushing to the ER that, we're going to go back again 10 years ago before ACA. Just, I don't know, is that going to happen or not? But I think that will encourage most of people who don't have health saving account, but if I'm not talking about the federal level, I'm talking about a state level to be able to deduct their health premium or get a credit back. Thank you.
Thank you for that. I think I won't be able to speculate necessarily about what the legislature is considering, but we are intending in upcoming sessions to continue the conversations around affordability and where there are opportunities to move policies forward that would address healthcare affordability generally. I might see Chicky or TK if there's anything else you wanted to speak to about the prior activities and conversations. But otherwise, I think that's something we will certainly take back.
Claire, no additional information from me other than, yes, it is definitely top of mind and top of everything. So we are working with all the different groups that we can work with in terms of figuring out what we can and cannot do. So at this time, as Claire said, we can't speculate what our legislators will want to do, but we are ready for whenever they want to engage with us to provide them with information and or other policy related policy or operational related information that they may need from us to help move forward any affordability conversations. And I'm not sure if TK is still here.
You had to drop.
Okay, yes, but we do work very, very closely with TK's team with the Division of Financial Regulation.
Anyone else have questions or comments? I am not seeing anything in the participant box, but thank you very much for your time and for sharing, and for others for asking questions. We're on our second and final public comment opportunity. Dawn, did anyone sign up in the interim when we last checked?
No, they did that.
Okay, thank you. Anyone on the line wishing to come off of mute and introduce yourselves and offer public comment? Okay, I am not seeing anyone. So I think with that, I want to thank everyone for being here. I know it's a really busy time of year, and wanted to wish you all a happy new year, and we'll convene again in 2026. Chicky, anything for the good of the order? Anything you want to add?
Other than, first off, happy holidays. And secondly, of course, with the timing of January 15th, that is the last day of open enrollment. So we recognize also that many of our community partners and agents who are on the committee may be very busy with the last day of open enrollment, but we will try to send materials ahead of time for your advanced review in case you're not able to join. And then Lindsay, real quick, I see Kathleen has her hand up.
Just saw that. Kathleen.
I'm so sorry. I'm slow on the tapping here. My apologies. I know I mentioned this earlier, but one thing that I am very concerned about for our populations that we are addressing is that Vibra Specialty Care Hospital has announced that they are closing. That leads to 310 employees that are out of work, as well as that's a number of beds that handle this. They're patients that are acute patients, but chronically ill. So they need longer hospitalizations, and they pay out of a different bucket of money for that services. It doesn't tap into their skilled days, and it doesn't tap into their hospital days. My concern for our payers is that they're going to end up with the patients lingering in hospitals for a much longer period of time. So just advocating on behalf of anything that can be done to advocate that we somehow breathe life into this specific category of care. I just wanted to highlight before our meeting ended.
Thank you, Kathleen. Anyone else have anything before we wrap for the end of the year? I'm not seeing anything else. Chicky, did you have anything else there to add, or were you good?
The last thing, of course, is when, so actually the last two things. So when the notice of benefit and payment parameters does drop and we are made aware of that, we will share with the HIMAC committee in case you and your teams would want to provide comment. And then also once the CMS releases the marketplace public enrollment snapshot nationwide, we will also make sure to share that with the HIMAC, and hopefully that will come sooner than later. And that's it for me, Lindsay. Thank you.
Thanks, Chicky. Okay, everyone, wishing you a safe and healthy December, and we'll see you in the new year. Take care. Bye.